it does seem that there's, kind of two camps like there are for so many things. People that do just fine with BCG, no issues, no problems. And then the other end of the spectrum are going to be the people that, they really have the fatigue, the systemic symptoms, the pelvic pain, discomfort. One of the things that I've started doing is actually for all my female patients that are getting BCG is starting them on vaginal estrogen. And I feel like their kind of vestibulodynia and discomfort has improved. I think that might be something, that could be beneficial. And then I've also had a handful of patients with extreme, what I would consider BCG cystitis. At their 3-month or 6-month cystos, their bladders just look terrible. I'm super worried that they're chock full of tumor, resect them, and it's all cystitis. And for some of these patients, I've actually been, once I've confirmed that there's no recurrence, having them receive hyperbaric oxygen therapy. But just kind of a couple of things that I've been doing. Any opinions, or have you seen any of these patients where you look in their bladders and they just look inflamed, angry, erythematous, telangiectasias everywhere?
It's really interesting what BCG can do. I actually had a patient recently he was getting treated for another secondary malignancy, but had a PET scan and his prostate lit up, which had BCG granulomas throughout it on biopsy. I've had patients with epididymal orchitis from the BCG, right? So it just is so inflammatory sometimes. And you're exactly right. I mean, the bladder itself can get really cystitis and everything else. And I think, you have to utilize some other therapies to try and get them through the BCG therapy, or just switch course to a different treatment option.
Even more reason to support the bridge trial. Toxicity, BCG shortage, etc. No,
I mean, are you guys using any? We rarely get to the maintenance courses for these guys. I mean, we're running through our BCG for induction courses and very rarely getting enough doses for maintenance these days. And I think talking to other folks, at least in academics and certainly in the community, very few people are doing maintenance doses due to the shortage.
Yeah, our maintenance literally earlier this month got axed. We were at full dose induction, 1/3 maintenance for up to a year. They had to have high grade, high risk per AUA guidelines. Now it's just induction, and it's tough. I mean, the patients don't like it, and I don't like it. Nobody likes it. And I've actually gone to some gemcitabine docetaxel maintenance, which is a little atypical, but
no, we started doing the same here.
You can judge.
No, we're doing it too.
Go ahead and judge, but it's like something seems better than nothing. All right, so now let's just jump into that 3-month cysto. Let's kind of walk through some clinical scenarios. So you look in the bladder, and it's erythematous, and they've got a history of CIS. First things first, you get a cytology and it's positive. What's your next kind of step in this scenario? Office biopsy, OR biopsy, is the cytology enough?
So cysto, seeing erythematous lesions concerning for possible CIS versus, BCG cystitis, and the cytology is positive.
Yeah.
I personally will take that patient to the operating room and under sedation at least do biopsies and fulgurate. I am a bit of a believer that I think there is a therapeutic benefit from trying to at least fulgurate some of the CIS. And I do, especially areas where, it looks like there could be some early papillary changes. I will formally resect those areas safely, at least. And then once in a while, you'll see that there is some lamina propria involvement. Usually it's focal and it's a small amount, but I think that's important to know because, that is a concerning feature. If the cytology comes back negative, unless I'm very worried about the patient, I don't often take biopsies. I would probably just proceed with roundup maintenance BCG and then reassess at 6 months. The concerning aspect of that is we know that many patients, based off the SWOG maintenance clinical trial data, will convert to a complete response, but not everyone will. And then they would, by definition, at that point, meet the definition for BCG unresponsive disease, having received induction plus maintenance. And the standard of care in 2022 is still radical cystectomy. So, it is unclear to me whether those patients would have done better if they would have received, a full second induction course of BCG. And we do have a clinical trial here where we're combining BCG with intravesical gemcitabine for patients who you would typically retreat with BCG, trying something a little bit different and hopefully getting better results.